by and large, when probably the scenario is not that bad, then you could think about contact lens rehabilitation, optical iridectomies, and rotational autokeratoplasties. So this is a condition where you'll probably like to put to use the alternatives to penetrating keratoplasties. Most of these children could be one-eyed children who have come out of their morbidity, both systemic and ocular. And when you see cases like this, you probably can look at alternatives to visually rehabilitate them. A word of caution when you're doing rotational autokeratoplasties: always rule out that it's not been a viral infection, because rotational autokeratoplasties don't do so well in viral etiologies. But if you're looking at post-traumatic corneoiridic scars or post-keratomalacia corneoiridic scars, then you have to plan your surgery well of how you're going to rotate. But remember, there is no margin for error when you're trephining. You're going to use a same sized graft to close on to the recipient window, so you need to be perfect in your suturing technique, and when you're doing your trephining and when you're cutting out the host tissue. And 2 is you're going to have a higher amount of residual corneal astigmatism in these cases. 3 is you have to, your technique needs to be perfect so do not cause any lens injury and add on to the morbidity in these cases. Earlier, people were not doing rotational autokeratoplasties for corneoiridic adhesions and were simply placing it for corneal opacities, but then a wise case selection can help you to rehabilitate these children with a 660 or a 624 without the need of glasses, and they could go on without the need for a penetrating keratoplasty. Again, I think Murli showed you lovely videos on lamellar procedures and the difficult scenarios in lamellar procedures. This is just to complete the picture and show you this is a pediatric DALC for an advanced keratoconus, a young child in whom I just have the IOCT to show you the picture. You find the bubble which is just dissecting beautifully. This is a D DALC, or what's a desmetic DALC, and you've seen the bubble forming here beautifully and captured on the IOCT as well in the right plane. It helps to see you, and this is when you do the brave slash, you just watch carefully. You will find the desmets falling back into position once you release the air out of the big bubble chamber. So just to complete, and I think Murli already touched upon all the nuances of lamellar grafting surgery in children. When you look at doing manual DALCs for post-chemical injuries, that's a difficult scenario, a totally different scenario, because you'll never be able to achieve big bubble DALC in these patients. And the manual layer by layer dissection is probably going to work out better for these. You also remember that these are scarred cornea, scarred ocular surfaces. The surfaces have been reconstructed with amniotic membranes, with slit procedures, and the cornea is thin and opaque in most cases. So you do not have the you cannot afford the luxury as you would do a manual DALC in clear corneas as in keratoconus. You have to be very careful. They have a high chance of perforation in these cases, and the corneas could be thin in several places as well. And so this is a more challenging scenario as compared to a DALC in a keratoconus. So where you need to remember is a higher chance of perforation. Use manual layer by layer. So you need to have perfected your lamellar techniques before you shift on to this procedure in pediatric eyes. Again, watch out for postoperative epithelialization. Look at the need for immunosuppressant therapy. We really don't know how long these grafts are going to survive, because I have particular concerns of raised post-operative graft infections in these particular patients, and if possible consider alternatives to therapy. Again, a post-let DALC, this is a post-keratoconus DALC in a pediatric eye. This is a post-let DALC in a pediatric eye. Not all cases land up with such wonderful results. I've had bad results as well in some of the cases, and this paper talks about our experience of outcomes of SLET and DALC in post-let eye. So I think I'll just skip most of the literature out here and go on to the challenges here. Remember, these are small globes. They have reduced scleral rigidity. They have high positive vitreous pressure. You need a good anesthetist to keep the eye soft during your surgery, and optimal preoperative planning is very imperative. Post-operatively, the need for repeated examination and anesthesia. This is a particular point you need to counsel the parents before you take these children on for surgery. And if they are not willing for a regular follow-up and for subjecting the child for repeated examinations and anesthesia, please don't take on these cases. You might have higher increased inflammation, but it's not a particular concern these days, given that our techniques have evolved to much higher levels these days. But yes, secondary glaucoma and immune graft rejections and infections are huge concerns in our scenarios. Something which I'm always bothered is rapid suture loosening, and you might have sutures loosening on consecutive visits as well, and even as early as the third week or the second week, and you probably would want to go ahead and replace these sutures when they loosen within a month. You would consider early suture removals, probably even at 3 months in these patients, because of the high risk of suture-induced infections in these patients as well. The challenge is to network well with your pediatric ophthalmologist and to visually rehabilitate these children so that a well done surgery translates into a good visual outcome is when you probably succeeded in managing corneal grafts in children. The particular goal is establish your diagnosis, establish and look for other corneal morbidities you have in these children, determine the visual potential this child is going to get, and the amblyopia management, plan it preoperatively. The comorbidities need to be optimally managed both preoperatively and postoperatively, and pair up well with your pediatric ophthalmologist for good outcomes. How is pediatric keratoplasty evolved today is, are we strong enough to do glaucoma drainage devices for these children along with our as a primary procedure? Most of us still don't, and we do it as sequential procedures, but the West is probably moving towards it. I think there are a lot of latest literature which is coming out with saying that pediatric K-pros are not safe, even in those people who are doing it, probably would refrain from doing keratoprosthesis for pediatric. And of course, yes, there is a shift towards doing higher and higher amount of lamellar procedures in these children. But remember, when you're moving on or you're a beginner, it's always best to be cautious and do it once you know that your complications have been lesser in your adult patients, and you can achieve better outcomes in your pediatric patients. When you are sure about it, then you shift on to lamellar procedures in children. These are the particular concerns when you're looking at pediatric grafting, graft infection, glaucoma, astigmatism, and an integrated treatment approach. Is usually not possible to get all these together. So if you are able to manage all these, then perhaps I think your results would be fantastic. But I'm really sorry, I don't know why all my videos are not running. So this is a particular case of a post-let talc who went on to gain a vision of about 660 to 624 and subsequently kept repeating with repeated graft melts. I've almost done 3 graft exchanges for this child, and now given up. She seems to be coming back with repeated ocular surface melts and secondary infections, and that's a particular concern which I see in these post-talc scenarios. So it's always not a story of success. It's a very mixed response when you do pediatric keratoplasties, but be geared up to tackle the challenge. Thank you for your patient hearing.
Thank you, Dr. Vanathi. That's very comprehensively. She has covered everything about pediatric transplantation. If there are any questions for Dr. Vanathi? Call upon next Dr. Somasheila. She would be talking on a surgical management of allergic eye disease in pediatric age group.
Very good afternoon, and I would like to really thank Murli for including me in your instruction course. Both of us, we practice at LV Prasad, Hyderabad, and Murli is basically the one who has the huge load of pediatric patients. I manage the ocular allergy, so I do see pediatric patients, but not to the extent that he does. And he has, though he speaks so calmly, he's actually very passionate about his patients, and he takes such good care of them. So we are very grateful that he's part of our team over there. So my presentation is very brief. I hope to just give you a few tips of surgery in pediatric patients who come in with allergic eye disease. As you know that we have vernal keratoconjunctivitis and atopic keratoconjunctivitis, which are the more chronic allergic eye disease, and they usually affect patients in the pediatric age group. So unfortunately, it is not self-limiting, though we keep telling the parents that they will, at least for VKC, they will, as they grow up, they'll sort of have a remission. But sometimes it progresses in adulthood also. So when all should we look at when we need to do surgical modalities for these patients? So the top few indications would be in cases of giant papillary conjunctivitis, and especially where it's causing a shield ulcer. We also need to do surgery in cases of steroid-induced cataract and steroid-induced glaucoma if it's not controlled medically. And as Vanathi talked about keratoconus in children, we also have patients who have VKC and keratoconus because it's very often associated with each other. And then the rarer cases would be in cases of limbal stem cell deficiency secondary to chronic allergy and cases of microbial keratitis. So coming to the first indication, what do you do for patients with giant papillary conjunctivitis? So I'm sure that all of you in practice have seen these patients with extensive allergy and this massive cobblestone papillae. So these papillae, both mechanically and due to the toxins that are secreted, cause repeated shield ulcers also in these patients. And of course, the patient is extremely symptomatic due to the allergy, keeps on rubbing the eye, loses days of schooling, and so on. So the best modality to take care of this problem is to take care of the allergy is to give a supratarsal steroid injection. You don't have to do surgical excision for this papillae. You just have to quieten the allergy. Don't do simple excision. I'm just put these down because they've been described in literature. People have done cryoablation. All of these aggravate the allergy. Some people have applied amniotic membrane. Maybe I would be okay with just applying the membrane without excising it. Some people have tried MMC and 5FU in very recalcitrant cases. The results are not very, very encouraging. So I've put the list down there only to discourage in general to do anything about it. The best case is that to go ahead and do a supratarsal steroid injection to take care of the allergy. How do we do it? Can use a simple 26 or 27 gauge needle. We need to take the patient if it's very small, and of course most of the time under anesthesia, and fold the upper eyelid, and there is a space where the tarsus muscle ends, so you need to find that potential space. You can choose the drug based on how much you think that you're going to have compliance from the patient and the parents. So are you able to measure the intraocular pressure? So I like to go with methylprednisolone in those patients where I'm not very sure that they're going to follow up, because methylprednisolone is short acting. It may last for about 20 days or so, and the pressure rise is not as high. Whereas if I have patients who are very reliable and I know they'll come for follow-up, I can measure the intraocular pressure. I would use triamcinolone, which is a longer acting steroid. So what happens is you give the steroid injection, there's dramatic results. By the next morning itself, the child is usually comfortable. Of course, monitor the IOP, and you can repeat it. Maybe 6 months later, the next time allergy season comes up, the child comes back to you again with this kind of problem. It is reasonably safe as long as you follow the guidelines that you need to do. So here's a short surgical video which will show you the same thing. So this is under anesthesia. We're using the surgical microscope. Already folded the lid. It's a very tight space, so which is a good thing. You can't get too much of the drug inside. You raise a wheel over there and just find the place and raise a wheel over there. You can inject very comfortably about 0.5 I think that is more than enough. You can inject less also. You don't need to inject any more than that. And just massage that area till you can spread some of the drug reasonably well. Sometimes you have to do more than one puncture because you can't find the site. And here you tried from one location, you couldn't find any space, so you can try it from the other location. And you can use 2 and 3 injection pricks because it is under anesthesia, and just inject the drug, and that's it. So it's a very simple technique here. Most of the drug is going subconjunctival. Some of it is going supratarsal, where actually the papillae are, to address the problem of the papillae. The only instance where I've had done something like an excision for the papillae was this particular young man. He's 16 years old, and you can see that his papillae are not only huge, but they're also, some of them are keratinized, squamous metaplasia.